Good afternoon. I'm Congresswoman Allyson Schwartz, President and CEO of Better Medicare Alliance, and welcome to today's webinar, The Drive to Value. It's a conversation on value-based payment arrangements, Medicare Advantage, and what happened during COVID. From President Biden's budget proposal to bipartisan bills on Capitol Hill, there's increasing recognition of the value of moving from strictly fee-for-service payment models in traditional Medicare to value-based payment models. Thus, the topic of today's conversation, value-based care in Medicare Advantage. Value-based payment arrangements between health plans and providers already exist in Medicare Advantage and have for a while, as it's consistent with the financing framework for Medicare Advantage, the Medicare option chosen by nearly half of all Medicare beneficiaries in Part A and B today. Medicare Advantage is paid a prospective per member per month capitated payment to cover all of Medicare benefits and is given the flexibility to use dollars saved from improved outcomes to cover benefits not included in Medicare Advantage, in traditional Medicare. This capitated payment system enables, in fact, incentivizes primary care, early intervention and intervention, care coordination that benefits all beneficiaries, particularly those with chronic conditions, including complex patients with multiple chronic conditions. This model of care is successful in offering quality care, improved outcomes, and high consumer satisfaction, and has also proven particularly important to providers as they've sought to sustain their clinical practices during and maintain access during the COVID-19 pandemic. There's no question that the pandemic has taken a toll on doctors' offices around the country this past year plus. As stay-at-home guidelines, elimination of elective procedures, and focus on protecting seniors and others from the virus by closing doctors' offices and hospital clinics for many months. Fee-for-service revenue essentially stopped for most outpatient clinical practices. One study reported 97% of physician offices experienced a negative financial impact directly or indirectly related to the pandemic, with practices reporting an average increase in revenue of 55%. Fortunately, Medicare Advantage plans that have been adopting value-based payment arrangements with health providers for years, meaning payments to providers in these arrangements continued during COVID, and as a result, made a significant difference in doctors' ability to maintain their clinical practices and care for their patients. It also means that these health plans and providers who contract together really align goals to increase outpatient care and coordinate care for patients that need it so they can get care at the right time with the right providers in the most appropriate settings. During COVID, there was a lot of conversation about that, and they could do a lot that traditional fee-for-service just couldn't do, like reaching out to patients and making sure they were doing okay. Overall, almost 50% of provider contracts with MA plans are value-based contracts of some kind, with providers receiving capitated payments rather than the fee-for-service payments for clinical care. One health plan, Humana, reported recently that over 2/3 of their Medicare Advantage beneficiaries receive care from primary care physicians who are in such value-based payment arrangements. This new kind of relationship between payers and providers helped health plan and clinicians work together during COVID and to be there for their patients at a time of a serious health emergency, particularly for those over 65, disabled, or chronically ill. As Modern Healthcare reported last year, quote, anecdotes from physicians, medical group administrators, health insurers, and other industry experts suggest that payers paid for value have had an easier time weathering the COVID-19 storm. Providers like BMA's Allies, ChenMed, and Oak Street Health, and Iora Health, and Atrius Health have all told us about the difference value payment made in their ability to care for their patients. And so what is the benefit for value-based care to patients? Well, and what are the benefits and needs that they can tend to that harness the full potential of these innovative payment models? Well, that's what we're going to be talking about today. I'm delighted to be discussing this with our special guest and my friend and Dr. Jerry Penso, who's president and CEO of the I almost said Better Medicare Alliance, of the American Medical Group Association, AMGA for short. Dr. Penso is a board-certified family physician who now leads AMGA, the trade association representing medical groups and specialty practices across the country, collectively representing over 175,000 physicians who care for patients every day. And AMGA is an active ally organization with Better Medicare Alliance. Actually, I'll say it was one of the founding ally organizations of BMA. And Dr. Penso is not only actively engaged in the work of BMA, he's also president of the board of our sister organization and research arm, the Center for Innovation in Medicare Advantage. So please help me in welcoming Dr. Jerry Penso. I can just switch scenes easily. So really what we want to do today is to talk together, Jerry. I'll call you Dr. Penso, make it more formal for this audience. And what we both agreed at the beginning is that we could just talk to each other a way we do easily. We'll be able to communicate a lot of information to this audience. But let's start with some questions so we can get going. Before we get into the topic at hand, tell us a little bit more about AMGA, the work you do. You've been so supportive of Medicare Advantage. What does it mean to your members? And sort of where are you and where are your members in this move from fee-for-service to value-based payments, accepting full risk in some cases? And you've been leaders in this field. So tell us a little bit more about the organization and your members.
Well, Allyson, it's great to be here. And as you mentioned, we were one of the founders, one of the early supporters of BMA and you. And we truly support the great work that BMA and that you are doing to strengthen and make sure that Medicare Advantage is available, not only to us as provider groups, but to our patients and our communities. So, I mean, it is a great program. And let me just take a step back before I describe AMGA a little bit. I'm a family doctor. And when I was in practice in San Diego, I was in practice for over 20 years as a family doctor and took all sorts of patients. I took Medicaid, Medicare, traditional Medicare, commercial, plus Medicare Advantage. And I will tell you, Medicare Advantage was my favorite type of patient population to take care of because it gave me the flexibility to take care of the patients the way they really needed to be taken care of. Because of the payment models, and we'll talk about that some more, I'm sure, it gave me and the medical group that I was part of the flexibility to deliver really a fabric of care that wrapped around the patient needs. And it's really unique in that regard compared to traditional Medicare, of course, but other health plans as well. And I think the patients really appreciated what we could do for them in that Medicare Advantage. So as a personal physician, as a family physician, it was just, it was great for the patients and great for the provider because it really aligns us to do the right thing. AMGA is a trade association. We represent over 400 medical groups, multi-specialty medical groups, health systems, integrated health systems across the country. We're in all 50 states. As you mentioned, collectively, there's 175,000 physicians who are in those groups. And because of the size of these groups, and we're talking groups like Cleveland Clinic, Mayo Clinic, Geisinger, Kaiser Permanente, Intermountain, Health Partners, large, prominent, what we like to think, elite medical groups and health systems across the country who take care of a large number of patients in their community. So if you add up all the people that we take care of, we actually touch the lives of 1 out of 3 Americans. And as far as value goes, definitely our groups are on the journey to value with Medicare Advantage, with their commercial health plans, and now even with Medicaid. So they're definitely building the infrastructure and the capabilities to deliver healthcare that really is suited to their model of care. Multi-specialty medical groups, that's where different specialists, family doctors, cardiologists, neurologists, all work under one roof together. And as you probably imagine for senior patients, that's real important that these doctors are working together, usually on one electronic health record and coordinating care.
Well, a great explanation and nice. Thank you for your own personal endorsement of what it's like to work under a system of more managed care, a capitated system. And again, we have people in our audience who are quite knowledgeable about Medicare Advantage, but some may not be. So just to be clear about what this really means, we use value-based payment, and value really is, a combination of quality and you get good quality, you can get better costs and better outcomes. And that's what it's all about. But it really is a change from episodic care, which really is the way Medicare started. You pay doctors the way most doctors are paid, and still in this country, which is you go to a clinician's office, they do something for you, they get reimbursed for your care. It's very different to get a lump sum of money and say, here, you have to go take care of all of these benefits and these patients and do and achieve better outcomes. That's the other thing in Medicare Advantage. There really is a requirement that you report on outcomes and not only what you've done to patients, but have you kept them out of the hospital? Are they going to the ER? Are you? And we've really seen a real change in that. But it also means that providers take a risk, that they are in a value-based payment, a capitated arrangement, some of them. There are a variety of them. Some of them take full risk for the services they're provided, and some don't. So that's a huge change for a lot of doctors who've worked under episodic care or reimbursement, to really saying, I'm going to take care of the whole patient. And of course, then there are the extra benefits that can help you sort of wrap around some of the social and other kinds of clinical needs, and as well as what it's like to work in a network. You represent groups that really have networks of doctors that then work together. So you're not searching for your doctor and wondering who are they going to talk to each other. A lot in that question, but tell us a little bit more about how providers have adjusted to this and responding to it.
Yeah, that's a great question. So what you're describing, we call coordinated care, integrated care, and it's perfect for the Medicare population. We know that people are living longer, and as you live longer, you collect chronic conditions. And Medicare patients, 65 and older, typically have a collection of chronic conditions, usually high blood pressure, diabetes, heart failure, maybe some behavioral health or mental health issues. I'm not saying all, of course, but as you get older, your odds of collecting some of these chronic conditions increase. So for example, 14% in the last survey I saw of Medicare patients have 6 or more chronic conditions. Well, you could see why that needs coordinated care. You're not just seeing, now I'm a family doctor, but I may work with the cardiologist, the nephrologist, and other doctors that are helping to manage all those patients' conditions. And that's real important. The other point I want to make, Allyson, because Medicare Advantage, like you mentioned, typically pays in a prepayment method, it gives the medical groups and the provider groups an opportunity to get really creative on how to manage the cost and, of course, the quality. So when I was with a medical group, we were looking at hip surgeries and knee surgeries. It's very common as you get older, you might need a hip replacement or a knee replacement. And like you said, the old model is, I call it find it and fix it. Your knee hurts, we'll fix it and put you in the hospital and take care of it. Where in a Medicare Advantage, my medical group and the doctors are all incentivized to make sure you have the absolutely best outcome, because we don't want you to get readmitted. We don't want you to have complications. We don't want you to have a bad outcome. So what we did in my group is we did a really proactive approach. So we looked at patients who were getting that surgery, and before they had surgery, I sent a care manager as well as a physical therapist to their house. And that way they could look at the setup, see if they needed equipment, get that delivered ahead of time. And the care manager might talk with the patient's family and say, here's what's going to happen when your loved one goes home. How are you going to take care of them? Make all the arrangements. Maybe a son or a daughter has to take some time off of work to help care and make sure that, and all of that you can see being proactive and making sure all that happens ahead of time is so much different than what I call the find it and fix it model. So our groups that's the kind of care that we deliver. Now add on some IT, some analytics, some quality improvement methodologies and support, a common electronic health record. And it is, it's really, I think, the best kind of healthcare, especially for seniors, but probably best for a lot of us to get that kind of, proactive, great care that is, again, it's ideally meant to keep you healthy, because that's the right thing to do, of course, but that also is the most cost effective as well.
Yeah, I think that's right. And we know it because we've had the Medicare Advantage plans do save money because they keep people out of avoidable hospitalizations, and then can reuse that and repurpose that money first to make sure that there's enough primary care providers and outpatient services, but then those supplemental benefits. Well, let's talk a little bit about how this all worked during COVID. We're all sort of coming out of it now, so we don't feel the pressure we felt 16 months ago of, we felt like the healthcare system was falling apart, honestly, in some ways, and in some ways responding beyond measure in a wonderful way to see these doctors and nurses and techs and actually people who worked in hospitals, everyone coming together to do absolutely the right thing around COVID, to make sure that COVID patients got treated. But then there are all the rest of us who, seniors in particular, who have those multiple chronic conditions, and they're told to stay home and not to go out. And what happened during that time, and how did Medicare Advantage payments help make sure that those patients, both the ones who obviously had COVID, got care, but then also everybody else who was just trying to figure out how to maintain their health and treat their chronic conditions and not go to the doctor? It was kind of confusing. So how did that help your medical groups be able to provide the kind of care that the patients needed?
Yeah, those were challenging times. If everyone remembers, April 2020, May 2020, and June 2020, many states had lockdowns. They encouraged everyone to stay at home as much as possible. And in the medical field, they encouraged, unless it was an essential service, for patients not to come to the office and to stay at home. And patients listened to that. They wanted to stay safe. And our practices wanted to make sure the patients were safe. So we didn't bring them in for those conditions. Most of our medical groups and health systems across the country, and most providers, aren't 100% into value. They have a mixed bag of different types of insurances. So even if they have some value-based contracts where they're getting perhaps some prepayments, or they're at risk for payments and getting rewards if they hit quality metrics or cost metrics, the vast majority have a mixed bag of different types. Well, what that means is that on your fee-for-service patients, if you're not seeing those patients in the office, if you're not doing procedures on them, like I mentioned hip surgeries or things like that, that aren't essential, your volume goes way down, and then of course your revenue goes down. And I think, as you mentioned in your introductory remarks, our doctors, our physician, our medical groups had a devastating drop in revenue that they had never seen before. And it was devastating. And they took action to make sure that they remained solvent. So there was cuts in physician compensation. There was furloughs of staff. There was, expense reductions all around, closing offices, et cetera. But meanwhile, they had to deal with the COVID pandemic. And that means they had to ramp up testing. They had to ramp up their ICUs to handle the volume, especially in certain areas that were getting overwhelmed. So it was this strange time of basically money not coming in, a lot more money needed to be spent on COVID and all the things there. In addition, they had to get protective equipment. If you remember back in those days, it was very scarce, and they had to work hard to source and save their protective equipment. So it was very challenging. And like you, I'm just so proud of the doctors, the nurses, and the entire care teams and the administrators who rose to the challenge and made sure that these groups continue to provide care for their communities. The saving grace was telehealth. So telehealth came in almost overnight. Many of our groups were seeing 20, 30 telehealth visits a month, and they ramped up to thousands a day. They literally had to get laptops to all their physicians and caregivers, get them trained up like overnight. And we're talking sometimes 2-3 days, get the patients hooked up, get all the technology to work so that patients who, especially like you mentioned, with chronic conditions, who had questions, wanted to see their doctor, couldn't see them in person because we're trying to keep themselves, could have these telehealth visits. And those were, if you will, a wonderful bridge for those patients. And I actually think we're going to have to figure out exactly where telehealth fits in the in the healthcare delivery system, because some patients think it's great where you don't have to get in your car, drive to the doctor's office, and can get your needs taken care of. And that was actually wonderful. And a shout out to the health plans. Many of the health plans, CMS changed the rules, waived a lot of the regulations so that telehealth was now much more available. But many health plans stepped up to the plate as well and made sure that physicians were paid for those visits, and that helped with some of the financial burden.
And I think that's right. And some actually, some of the plans actually offered some advance payments. Yes. And that was helpful as well. And some of them were more geared up for telehealth than fee-for-service was. But you're right, everyone had to just step up and really change very, very quickly on telehealth. And I think we agree that we'd like to see telehealth continued. How exactly that's going to be done now in Medicare Advantage is going to be a wider opportunity to do that. Again, not because it's not paid exactly fee for service. They can do some of that. In fact, one of our reports showed that there were fewer no-show rates for behavioral health, which was really fantastic. So maybe that works. I know a lot of people who are doing mental health visits, the psychologists were saying, I'm busier than ever with social isolation, depression, and the stress that people were going through really also exacerbated that for adolescents as well. But we're talking seniors here. But maybe their family didn't want to visit them. They didn't feel like it was possible or safe to do that. So it really became a really important tool for all of us, not to mention all of us who have been on Zoom meetings every day for the work that we've done. Appreciate what CMS did in stepping up to the plate and really making waivers. BMA was very involved in advocating for those waivers. We want to be sure that those issues around there, make sure we have the data that we need in MA that wasn't available at all through telehealth. Some patients reported and really had difficulty with not having access to broadband, didn't have the right devices, needed to do audio only. That became a real issue. My husband was doing telehealth visits from home, so I got to at least hear some of it, hear side of it a little bit, but I would hear him saying, okay, we'll just switch to the phone. If you really can't handle this, you're really frustrated, let's switch over and we'll try this again next time. People got used to it, but there were times when he would talk to patients he had seen for a while and get them through, that visit and save them the stress of coming into the office and the safety. So that all worked for sure. But the fact that it also helped financially was kind of interesting. We've heard that some providers have said, they really ought to want to do more of value-based payment arrangements because, in fact, it's a different way to just know you have that, providers have that financial security. They have to worry about risk and all those kind of issues, but it also became, you knew that you were getting those dollars coming in and that you could use them in different ways to get patients. We had one medical group that was giving tablets to some of the patients in their homes. They were delivering tablets so that they could have that visit and then picking them up again. So they really just went well beyond, what you would imagine a doctor's office would do, as well as the kinds of meal deliveries and focus on food deliveries and medication deliveries and the things that, it's good when doctors tell you to do these things, but then if you can't, you need a little help to get there. And I think lessons learned from that as well. But so I guess this really sort of says, what does this mean for the future of practice? You start out by saying how this is so valuable for you as a physician when you practiced, and you see it in the groups that you have who really have a tremendous amount of impact in their communities in transforming the way care gets delivered, in really viewing the whole patient as a whole person and looking at their needs over time and really helping them manage their chronic conditions so they can be healthier. So where do you see this going? I mean, we see this momentum. We hear about it all the time. I'm in touch with researchers because, as you know, as the chair of our Center for Innovation in Medicare Advantage, when we do these reports, we hear more and more that it's a greater satisfaction for doctors and greater satisfaction and better care for patients. So how do you see this growing? And do you think experience in COVID helps move us in that direction? Do you think there'll be even more interest in the part of your groups we're certainly seeing it in terms of enrollment, and I can speak to that. But tell us a bit about, from the doctor's point of view as well.
Well, I think the trauma of COVID for our provider groups, and I hope I've laid a picture of what the finances and the care looked like for those few months, was pretty traumatic for the medical groups and the health systems. And I think they're all revisiting, what is our business strategy? What kind of contracts do we want to do? And how are we going to do this maybe differently and be better prepared for, hopefully not the next COVID, but be better, have more resilience in our business operations and really be able to withstand shocks to the system like we saw. So yes, I think the destination is value. Our medical groups and health systems realize that they are moving in that direction. And the question is, how do they build the infrastructure and the partnerships to do so? So I would start with the fact that you have to have a great relationship with and a long-term strategic relationship with your health plan. The health plan has to be a partner in this, working together, because you don't go to value in 1 year. It's a multi-year journey, and it requires trust. It requires trust between the plan and the provider and the medical group and the health system in order to get through the bumps that happen as you move to risk. It requires data exchange, so where there has to be some transparency so that the health plan can, for example, let's take high cost, high risk patients. Those are patients that perhaps could end up spending a lot of money. Those kind of patients need joint management, if you will, between the health plan, often coordinating the benefits, and the provider group coordinating the clinical care. So there's an example where the health plan and the provider have to trust each other and say, you take this part, I'll take that part, and we're going to work together to the betterment. And then on the provider group, it's a challenge because it's a change in leadership and mentality. It's really a change in culture. You have to take care of the patients, but you have to develop your entire systems, be it care management, be it hospital care managers, be it a hospitalist system, be it high risk, like I mentioned, high risk, high cost patients and how to manage them. That you need that whole wraparound, or what I like to call a fabric of care. And that takes time to develop, but it's also a shift in, again, how we used to, as you mentioned, how we used to take care of patients. So what I would say is value is a journey. We're not going to get there overnight, but I would say most of my members have told me they're looking harder and harder at how they're going to move faster towards value.
Which is great. It really is. We would always say they have their own goals, and then you have the provider and they have goals, and they sort of have to battle each other, to get where you're going. And what this changes, I'm not saying this is all a love fest, as you said very gently, this is a journey, and it's hard, but you really laid out a path, to do this. And it is a changing culture for providers and a changing culture for health plans as well, to really be able to say, look, we can align the goals. And that's what I like to see is happening. And under Medicare Advantage, we're a goal. The goals are to get people to a better outcome. You have to take responsibility to do that. And I actually say, well, it's a little change for patients too. Thinking about this is that, we always say patients have to take their responsibility too. But I thought increasingly understand that you have to know where patients are. You have to meet them where they are. You have to be able to move them along this journey as well in saying, this is one that works. And increasingly, though, we're seeing, I'll just mention it here in terms of enrollment, really dramatic numbers in enrollment over the last few years in Medicare Advantage. So it's clearly working for patients. It's working for consumers. It's lowering costs. We know that on average, it's over $1,600 a patient, saving for a lot of seniors who live on less than $30,000 a year. Just really count their pennies, and being able to get some of those supplemental benefits really matter a lot. Being able to not have to pay. Many are in zero premium plans where they pay nothing extra, and they get this care coordination, and they appreciate. We did a poll on this. They actually like a network of doctors working on their behalf. It's often seen as that's a negative in MA, but you also can see it as a positive, that this is a group of physicians who, as you point out, are sharing data, sharing information on medical records. One doctor can know what the other doctor is doing. or other kinds of practitioners as well. So it really is changing healthcare, I think, in a very exciting way. And, COVID might, have pushed that along a little bit more, but it's great to see your groups are really taking such leadership, in this way. But so are patients. They're moving with their feet. The number I gave in the beginning of this conversation, we've been using 42% of Medicare beneficiaries are in choosing Medicare Advantage. But just recently, there's also a breakdown. CMS has always done that. But only people who can choose Medicare Advantage have to have both Part A, which is the hospital benefit, and Part B, which is the provider benefit. They have to be enrolled in both. If you take just that population, it's 49% of those beneficiaries who can choose Medicare Advantage or choose it. It's really astounding. So in some ways, the healthcare system has to respond and take this seriously and do better on costs for beneficiaries. And that's what they're doing. So I guess almost last question I think that I can ask, and then we can turn to see if the audience has some questions, is we have a new administration in Washington. The Biden administration is there, new CMS administrator and new HHS secretary. And I will say that Secretary Becerra has made good comments about the importance of Medicare Advantage to the beneficiaries who are in it, the additional benefits being really important. And the goals that have been laid out by both the secretary and by the administrator are, they have to deal with beyond Medicare. They have to deal with they're dealing with ACA and access and all that. But then overall, what they want to do is lower consumer costs. They want to make sure that, about quality and concern, particularly about disparities and health disparities and the inequities that we see in health status, particularly for minority beneficiaries and poor beneficiaries. We think that Medicare Advantage can play a role in that for sure. And then, finally, that we should move in this direction for value. So we think Medicare Advantage does all three of those things, that we really have a chance to really work with this administration. But it really means making sure that they understand what Medicare Advantage is doing for providers and patients. So how do you see the administration, or how AMGA will be working with the administration to make sure that we protect and strengthen the option of Medicare Advantage and help providers be able to move on this journey?
So I'm going to start by not answering your question. I'm going to rewind a little bit to, again, the other thing that we faced back in those days, remember in May of 2020, was the murder of George Floyd. And that, I think, brought to most of our attention, and this does lead back to the Biden administration, a real focus on health equity. And one of the data points that I learned from you, Allyson, is the fact that Medicare Advantage is actually more popular, more enrollment at the lower socioeconomic classes and among our African American and Hispanic populations. So Medicare Advantage is a wonderful mechanism to actually address health equity and make sure that those patients do get all the high quality metrics that are part of Medicare Advantage and wraparound coordinated care. So I just want to make sure to mention that, because I think health equity is an important it's important to my medical groups and health systems. We measure it and we try to improve on it and are addressing social determinants of health. But it's also very important, as we've seen, to the Biden administration. And we look forward to working with the Biden administration, letting them know what our groups are doing, but also looking for any ways to improve the care disparities that we see in the country. Our other issues, we mentioned telehealth. When the public health emergency ends, the telehealth waivers are scheduled to go away. So we want to make sure those continue and that payment parity continues for those telehealth visits, at least until we can measure what is the value of them, what's the cost, what's the impact, how do we bring that in, how do we bring that part of modern medicine now that we've unleashed, if you will, the genie's out of the bottle, how do we keep that now as part of the Medicare program and Medicare Advantage going forward? Medicare Advantage, of course, we want to strengthen and make sure that there aren't cuts in the future. The 2% Medicare sequestration cut was put on hold during the public health emergency. It's It is scheduled to come back into effect in January of 2022. We want to see that also continue to be put on hold. There's also a 4% potential cut in Medicare that's on the horizon in 2022. That was part of the initiative with Biden's COVID package earlier this year. There was a PAYGO initiative that was mandatory that could result in a 4% cut. So again, the 2% cut and 4% cut would be devastating to the finances of our medical groups and health systems. So we'd like to make sure that those don't go forward. And then finally, as I mentioned, data access. We talk to our medical groups and health system. The way to make value go forward is to make sure that there's good data exchange between the plans and the medical groups. And it's got to be two-way data exchange so that we can manage that care. You need to know where the patients are, what they're doing, what we're spending it on, so we can all manage it together. So those are our priorities. And we're pretty confident that the Biden administration, like previous administrations, will continue the march to value, and we're going to be right there with them.
And I appreciate you amplifying that. Usually we just switch sides there, switch places there. Usually I say some of that, you're right. But it is really true that I think that there is both a tremendous opportunity to address equity issues in healthcare through Medicare Advantage. Again, because the population is minority population. More than half of Hispanic seniors, I think it's over 60% of Hispanic seniors are in MA. So, I mean, it's a huge opportunity as well as obligation to use the tools that exist in an integrated managed care model to really make sure that you talk about trust between plans and providers, build that trust with the health system that you're in, with your patients, and to build that kind of ongoing relationship where you understand who that patient is and really can give them the kind of care that they deserve. And coordinated care is not a given in healthcare today. And it's really, MA has been in the leader in coordinating care and making sure that people understand what they're going through and what's before them and what might come next, and how having all these different conditions impact each other and need to be dealt with together if you're going to manage them well, as well as some of the social needs. I think there's no question that it's recognized that there needs to be attention to these social needs. As a long ago trained social worker, it's like there'll be no surprise to any of us. I went into the social policy side of social work, but it's really part of my understanding is that you need to be attentive to people in the environments they live in, the situation they live in, their family support systems. All of that makes what they can do personally. All of that we know matters enormously. So there are real opportunities ahead and excitement about this. So I'm really, appreciate all your comments and your clarity of what it takes to make it happen, as well as your optimism about it happening, which is great. Let's see, do we have any questions? I just want to be sure that there's an opportunity for some questions before we end. Jonathan, you're monitoring that?
Yes. Hi, Congresswoman. We've got one question in the queue, so I'll just give a reminder to everyone that you can ask a question using the chat box or the Q&A feature at the bottom of your screen. This question comes to us from Linda, and I believe Dr. Penso addressed some of this in his last response, but maybe we can just quickly see if you all have anything to add here. She says, Dr. Penso mentioned the need to figure out the role of telehealth in a post-COVID world. What is your view on the use of telehealth after the pandemic? What flexibilities should be permanent and what should be allowed to lapse?
Jerry, you did mention some of those. You want to elaborate a bit, and I'll mention one of the things that's an issue in health plans.
Yeah, so there's regulations and then there's payments. So let's start with the regulations. Before the pandemic, before the public health emergency, telehealth was extremely difficult. And there were all these regulations about who was where, that the patient may have to initiate the visit, and made it very challenging for physicians and other caregivers to implement it. There were even rules that, tightened up the restrictions so much with even pharmacists doing telehealth visits, and they're getting more involved with this as well. So let's just say in general, we like the waivers that got rid of sort of where the patient had to be, where the doctor had to be. We like getting rid of some of the regulations as far as some of the technologies that could be used, and geographic restrictions. Some were only available in rural areas, some of the waivers. So we want to make sure that those are lifted. You know, the big challenge for our medical groups and health systems right now has to do with some of the state regulations, you know, and licensure, where a physician to do a telehealth visit has to be in that actual state and licensed by that state. And that makes it very challenging. You know, let's just say you're a patient up in Minnesota and you travel down to Florida and you want to have a telehealth visit with your own physician back in Minnesota. That can be really challenging, even right now with some of the regulations. So sort of a national way of licensing physicians for telehealth visits would be very welcome as well. The payment, the issue is prior to the public health emergency, telehealth visits were paid at a very minimal level, if at all, by any of the health plans or CMS. So with the public health emergency, as I mentioned, there was payment parity. So if you did the equivalent of an office visit, but through a telehealth, you got paid the same amount. And we'd like to see that continue, as I said, at least for a few years, so we can study the impact. And it can, if you will, sort of find its level, find where it fits in. You know, let's just say you're a patient with diabetes. It used to be you had to come into the doctor every so often. Could we change that and perhaps make some of those visits virtual so that you stay at home, you don't have to come to the office and park and come, you know, unfortunately wait at the doctor's office and all the things you have to do there? Could we do some of those visits, which are really coaching, counseling, and maybe a little bit of medication management through telehealth? So that's what we're trying to hope, that we give telehealth a little bit more rope so that we can see how it fits into the system. Many of my physician groups have said that it works wonderful in certain things. Congresswoman Schwartz really mentioned behavioral health. That's been an area where there aren't enough behavioral health providers in this country, and making them more efficient through telehealth has just been actually, it's a game changer as far as I'm concerned. And that's just one example. So we'd like to make sure that those sort of innovations that we saw with COVID-19, the pandemic and the waivers are allowed to continue, and we see where they end up.
Absolutely. I'll add one other thing that's come up. I mentioned a little bit in my comments is that, well, maybe just a couple of things is, you mentioned geography here too, but there are issues of broadband access. So we need to, do more. That's maybe more of the infrastructure that's beyond healthcare, but it exists as a problem that not everybody has the technology beyond their control to be able to do this. But then some also can't afford the tablets or laptops. And we need to sort of figure out where audio only fits into this. And certainly looking backwards now, this is more about, anyway, the data that gets collected, Medicare Advantage plans, providers have to provide the diagnoses every year on every patient. So that seems, okay, we can do that. But if this was a year that you only had telehealth visits and you only could use audio, you have no diagnoses. Yeah. It doesn't make any sense. Everyone sort of agrees it doesn't make any sense. We want the data to be as correct as possible. Probably did not go away during COVID. And if anything, may have gotten worse, but hopefully you had enough visits with your doctor and you were able to be fine. But we don't have that data. So we're trying to work with CMS to see how they can, whether they use 2019 data and they carry it over, they use 2 years, or whether they allow the data that was collected through audio calls only to be used just for during the public pandemic. And then of course, if they go on with telehealth, where does that fit in to the identification of diagnoses that leads to identification of risk, which leads to payment. So it's a little in the weeds there for the audience, but there's an audio only bill that in the House, in the Senate, that we're supporting that would make the adjustment for the public health emergency and make sure that there's adequate payment going forward for these patients who still have these chronic conditions, but they couldn't have in-person meetings. So a little in the weeds, but yes, it's really going forward. There are issues around telehealth. I think there will be we hope some waivers on it, but we hope that answers the question. Think of, you gave a really good help on that in terms of answering this question. Jonathan, anything else?
Yes, Congresswoman, we have a question from Jacqueline. And she asks, and I believe this could be for either or both of you, but she asks, she says, you mentioned the role of payers and providers and care collaboration. Could you speak to the role of agents in this process?
Oh, yes, I guess we could. In fact, we also should be clear, and I'm happy to add to this, be clear about the fact that in this case, we don't mean just plain doctors and plans. It also are other providers and practitioners who have to weigh in this as well, and getting them all working together as a team and aligned in the same direction. I think she's talking about agents and brokers, and we are certainly, we have agents and brokers associations with us. The underwriters are one of our allies, and they have talked a lot about a couple things. One is making sure that the enrollment process, that beneficiaries, as particularly initial beneficiaries, as they just turn 65 and are getting information about Medicare, they need accurate and complete and fair information about both traditional Medicare and Medicare Advantage. And we need to be able to make that enrollment process clearer and understandable to everyone, which means level of literacy has to be correct, that language access has to be increased. Now, materials in English and Spanish only, that should be expanded, but that agents and brokers, and I will also mention SHIP counselors who are paid by the government and often in area agencies on aging, who counsel patients on this, need to be well informed about both traditional Medicare and Medicare Advantage, and be able to help people make that choice. We know from our own polling that there are many people who are in traditional Medicare who actually would almost half report not having heard about Medicare Advantage, certainly not initially, which is why we see enrollment happening a year later or even 2 years later, when they start to look around and say, can I do something that would help me meet my financial needs as well as meet my healthcare needs? And the handbook in you has gotten better and better on this, and the plan finder has gotten better, but we at BMA have other suggestions about how we can continue to move forward. More collaboration with Social Security Administration, where you get your initial information, and just ongoing help as well. So I know agents and brokers do that as well, but beneficiaries need that information as they enroll initially, and can change enrollment year after year as their healthcare needs and their financial needs might change. So if you want more information about that, you can be in touch with us as well. But it's something that we at BMA work on to make sure that the enrollment process is as streamlined and understandable and easy to access. We're not all there yet. We think there's more work to be done, but we've been very grateful for the previous administration that's done a lot of work on this, and hope the new one, and we know the new one administration is already engaged in making sure that this is user-friendly going forward. A lot of seniors, 10,000 seniors a day, a lot of people out there asking information, and their families can too. So if you know someone who needs information, by all means, do all that you can to get some advice from either an agent or a broker or a SHIP counselor. Involve your loved ones if you need to. And if our information on our website is helpful, we also have a beneficiary website called Medicare My Way that also provides some information. We don't do enrollment. That website is very much for people also who can find some initial information about MA. And if they do choose MA and want to work with us as an advocate, they can sign up to be a beneficiary advocate as well and join the 500,000 who have already done so. Would really be great. And with that, I think I want to end. And Jerry, you want any final words? Anything you want to add to us before we close out our session? You've been terrific at both giving us your time and your expertise and your knowledge in how this all really works for people.
No, it's just been great talking with you, and continue the great work of BMA. We really appreciate being your partner.
Thank you so much. And if you're interested in AMGA, you can go to their website and find out a little bit more about the work they do. If you're interested in BMA, go to our website, check us out, follow us on Twitter, follow us. We do a good bit of social media, and we do these webinars pretty regularly. So by all means, look for our next webinar. And if you're interested in staying informed about a Medicare Advantage, you can sign up for our policy alerts, and that'll keep you being very smart on Medicare Advantage and knowing what's going on. So, and to our allies on the call, thank you for the work that you do every day to take care of beneficiaries of Medicare Advantage and continue to lead the way on some of this really important work that you're doing for beneficiaries. So, Jerry Penso, thank you so much. Everyone take care, be well. I always say wear a mask, but I guess that's sort of when you need to. Take care.